This part of the beta blocker lecture will be very clinical. If you watch this lesson for your exams, for example, PLAB or USMLE Step 1, you may skip this part. But if you watch this lesson for USMLE Step 2 or Step 3, or for your clinical practice, you may continue watching. Attempted suicide or accidental overdose with beta blockers may have severe manifestation. There are certain drugs that exacerbate effects and worsen toxicity of the beta blockers, such as non-dihydropyridine calcium channel blockers like verapamil and diltiazem. Even topical beta blockers such as timolol eye drops given for glaucoma can significantly interact with verapamil and can cause severe bradycardia or AV block. Symptoms of beta blocker toxicity can be bradycardia, AV block, hypotension, hypoglycemia, decrease in cardiac output, acute decompensated heart failure, and cardiogenic shock. Blockade of beta-2 receptors in the lung can cause bronchospasm and respiratory depression. You may auscultate a whizzing sound on the lung. Mental status can be changed. Patient may be agitated, may develop convulsions or coma. Let's simulate the beta blocker toxicity. First of all, you can see normal vital parameters here. On the right upper part, there is heart rate. In the middle, oxygen saturation. Below it, we have arterial blood pressure, mean arterial pressure, and respiratory rate. Now let's simulate beta blocker poisoning. Beta receptors are in sinoatrial node. Blocking them decrease heart rate. Blocking beta receptors in AV node may cause AV block. Beta receptors are in atrial and ventricular muscle as well. If they decrease cardiac contractility, stroke volume and cardiac output will fall, manifested as systolic hypotension. At the beginning, blood vessels will try to compensate, will try to vasoconstrict, but cannot compensate fully. Blood pressure will drop and patient enters in cardiogenic shock. You can see on the screen a theoretical patient with bradycardia, complete AV block, and cardiogenic shock. This patient's blood glucose will be low, suggesting hypoglycemia. ABG will show metabolic acidosis. Central venous pressure will be elevated. Due to acute left ventricular failure, pulmonary congestion may develop, and bronchospasm develops due to bronchoconstriction. A patient's lung will try to compensate metabolic acidosis, hypoxia, and left ventricular congestion, and increase respiratory rate. All these will be manifested by desaturation and tachypnoea. A patient's vital parameters may be like this. As you see, a patient requires immediate support, because if left untreated, this condition may lead to asystole and death. During bradycardia, you may give atropine to increase heart rate and start giving epinephrine, norepinephrine, dobutamine, etc. But unfortunately, this is the condition when a myocardium may become relatively refractory to pharmacology and electrical stimulation. These drugs will not be as effective as in other disorders, especially catecholamines, because beta receptors are blocked. Management must involve giving antidote, which is glucagon, and let's explain this. To manage beta blocker toxicity, start isotonic crystalloids. It may not work, but you have to give atropine in case of bradycardia. Give glucagon IV, which is antidote. IV calcium salts like calcium chloride or calcium gluconate. This will help increase in inotropy and blood pressure, but will not increase heart rate. Calcium salts are particularly important if patient took beta blockers and calcium blockers at the same time. Giving IV vasopressors, especially epinephrine, is crucial. Intravenous glucose with insulin must be given for hypoglycemia, and if patient took lipophilic beta blockers like propranolol, metoprolol, labetalol, etc., you can give lipid emulsion therapy. To explain this final thing, this is propranolol. As you see, it's not charged, and uncharged drugs are lipophilic. Lipid emulsion is parenteral IV nutrition that contains lipids. A point here is that lipophilic beta blockers will be dissolved or engulfed or trapped inside the lipid emulsion, like this, and this will decrease circulating levels. It's crucial to know the specific antidote. It's glucagon. This is the cardiac myocyte. As you see, beta-adrenergic receptor is blocked. Glucagon receptor is also GS-coupled receptor. It can activate adenylyl cyclase. If you give glucagon in case of beta blocker toxicity, it can bypass the beta receptor and activate adenylyl cyclase, leading to accumulation of the cyclic AMP, increasing contractility, increasing heart rate, and improving patient's condition. So to summarize, Glucagon is antidote for beta blocker poisoning. I know it may seem a bit hard, especially if you are at early stages of your medical education. I hope you understood this clinically oriented topic, but if not, you are more than welcome to ask me questions. I wish you all the best of luck.